Thank you very much. I'm going to be talking, as Christian said, about how you can support and help your child to get the best out of therapy. And towards the end, I'll talk specifically about remotely delivered therapy, because obviously that's something that has affected many of us over the last 15 months in the context of the pandemic. So I'm just going to start by talking a little bit about CBT. So although the title of my talk is therapy, I'm going to be focusing specifically on cognitive behavior therapy. And that's because this is the only psychological treatment that is has a strong evidence base. So it's been shown in many, many research studies to really work in treating OCD and BDD, including in young people. And it's the only psychological treatment that is recommended in the national guidelines, so the NICE guidelines. And just briefly to recap on what CBT looks like, it usually involves 14 to 20 weekly sessions, although of course that can vary. Some people require fewer sessions to get better. Some people need more sessions. I will point out that in our experience, young people with BDD often require a slightly longer course of treatment than those with OCD. So for example, in our clinic at the Maudsley, our standard package of treatment for young people with OCD is 14 weekly sessions, whereas for BDD, it's 20 weekly sessions. And the main technique that we use in cognitive behavior therapy, the active ingredient, if you like, is what we call exposure with response prevention. So exposure involves helping a young person to gradually face up to their fears, face up to situations that make them feel anxious. And the response prevention bit is about helping them to resist the urge to carry out a compulsion, a ritual, a behavior in order to reduce their anxiety in that situation. So for example, a young person with OCD might be encouraged to, if they have contamination fears, they might be encouraged to touch a door handle and resist washing their hands afterwards. A young person with BDD might be encouraged to go into a social situation without trying to camouflage or hide the aspect of their appearance that they're really worried about. And the reason that we do that is that we know if young people are able to carry out exposure with response prevention tasks, although they get anxious in the short term, that anxiety does decrease gradually over time, just naturally, it comes down. We call that habituation. And if they keep practicing it again and again, eventually it gets easier and easier and they don't feel anxious at all anymore. So this is the main tool that we have in CBT. And it's something that we practice in sessions with young people. So we call that therapist assisted. We're physically doing the exposure with response prevention tasks with them. And we also ask them to practice it in between sessions as homework. And that's really, really important in the treatment, that practicing in between sessions. Another really important component of treatment is parent involvement. We always involve parents in treatment, and that's to varying degrees depending on the young person and the sort of details of their difficulties. It depends a bit on their age. It depends, for example, on the extent to which parents have got drawn into rituals or routines and the impact that OCD or BDD is having on them. But we as clinicians really view parents as a hugely positive resource and often refer to them as our sort of co-therapists in treatment. So probably that's all fairly familiar to many of you at least. So that's what CBT looks like, and hopefully also familiar to you is the fact that CBT for OCD and BDD really works. It's a really effective treatment. And we know that if it's done in the right way, about 80% of young people get better. Having said that, we also know it's a really hard treatment. So this isn't a passive treatment that people can sort of passively receive. It's a treatment that people have to actively participate in, actively engage in. And it's really hard. Many young people may feel that actually the hardness, the challenges associated with CBT are insurmountable to them, and they start to feel that they don't even want to give it a go, or they give it a go and become very hesitant, and their engagement starts to waver. So what I'm going to be talking about in the first part of this talk is what might be some of those challenges. What are the barriers to young people engaging with treatment, and what can we do about it? And when I say we, I'm referring to us as clinicians as well as you as parents. So obviously the responsibility can't be entirely on you as parents, but I think if we're all on the same page in how we're thinking about it and conveying the same messages, that's going to put us in a much stronger position. So these are some of the kind of common barriers that we hear young people say. Often they say, it's just too hard. They might say that it won't work. They think it won't work. They tell us that they can't talk about their OCD. So how can they get going with a psychological treatment if they can't even talk about OCD? Young people with BDD might say, I don't have BDD. I really am ugly. My problem is a physical problem with my appearance. It's not a psychological problem. Young people with OCD might say, well, OCD is just part of who I am. It's part of my personality. I just have to live with it. Or they might say, OCD is not a problem for me. And very commonly we hear young people with BDD saying that they feel cosmetic treatment is the only possible solution. It's the only answer to their problem. Psychological treatment can't work. So what can we do about this? And again, it's the collective we, you as parents or relatives and us as clinicians, how can we help young people overcome these barriers and promote their engagement in treatment? So thinking about that first barrier, it's too hard. Chloe touched on this earlier, and for those of you who heard her talk, I think when people say it's too hard, that is often rooted in anxiety. And there are two sort of facets of that anxiety. Sometimes it's a fear of the unknown. So it's literally just not being able to sort of visualize what the treatment's going to involve, what's going to happen. There's too much of a mystery around it. And there's a huge level of anticipatory anxiety that is stopping them engaging. The other side of it is a more specific fear, and it's a fear and anxiety around doing exposure tasks. So young people might have already had some experience of trying to do exposure, or they might have just heard about it, they might have been told about it, and that fills them with a sort of sense of fear and dread sometimes, and they just think they won't be able to cope with doing it. So what can we do in these situations? I think where anticipatory anxiety is at play, this kind of fear of the unknown, it's just so important that we give young people a really clear and very concrete idea of what to expect. So that includes how many sessions they're likely to have, where those sessions will take place, who the sessions will be with, how long they will last, will they get a break or not, and also a bit about the content of the sessions. So if that's something that you as parents know and are able to share with the young person, that's incredibly helpful. If it's something you don't have the answer to, then you can support the young person, your child, in finding out those answers, perhaps by liaising with the clinician, setting up a phone call. If sessions are actually going to be in person, you could perhaps take them to visit the clinic ahead of their treatment starting so that they feel they have that sense of familiarity. And sometimes this on its own is enough to really allay some of the anxiety associated with treatment. Where the fear is more specific to carrying out exposure, the main message that we really try and convey, and that you can help us to communicate to your children or your relatives, is that we really break exposure down into manageable steps. It isn't jumping in at the deep end. It's something that's graded. We use what we call a hierarchy to map out the exposure tasks in a very manageable way. And it's absolutely crucial that the young person feels that they're in the driving seat with that, and that there won't be kind of expectations or pressure put on them to do things that they're not comfortable with. Of course, the task will trigger anxiety. That's kind of inherent to doing exposure, but they will be dictating the pace that they work at. And the other thing that we can remind young people of, and Chloe also mentioned this, is anxiety psychoeducation. So I'm saying remind the young people that they may not have heard about this before, so it may be actually telling them for the first time. But the most important messages are that anxiety is normal and it can't harm us. A lot of people with OCD and BDD have very high levels of what we call anxiety sensitivity, which means that they perceive anxiety as being something very, very threatening to be avoided at all costs. So we really try and reframe anxiety as something that's normal, and it's our body's way of protecting ourselves. We talk about it being like the body's alarm system, and we sometimes talk about the fight or flight response. So it's a natural human reaction that we have, and it's very helpful in many situations. And we also talk about the fact that anxiety doesn't last forever. It does come down over time. And so just reinforcing these messages can sometimes give young people the confidence to take the next step and think, okay, I'll try pushing myself out of my comfort zone just a little bit. What about if they say it's not going to work? This is something I think we hear quite a lot in our clinic, because it often is the view of young people who've had CBT before and haven't got better. And in our clinic, most of the young people we see have tried CBT before and obviously are still stuck with their symptoms. So it's quite natural for them to think, well, it didn't work before, why will it work now? And I think here the main messages that we need to be communicating is that CBT is quite an umbrella term, and there are different versions of CBT, and just because it didn't work before, it may be that the next time you try CBT, it's going to actually look slightly different. There'll be slightly different active ingredients in it, and maybe that's what's going to make the difference for the young person and help them move forward. And not only can the treatment be different, but the young person might be different. Perhaps the last time they tried it was a couple of years ago, and they're older now, they're more mature, they may have more insight into their difficulties. So all of these factors changing mean that we should remain optimistic. Just because it hasn't worked before, it doesn't mean it can't work in the future. And in fact, we've done some research looking at this, young people who haven't responded to previous CBT and then come to our specialist clinic, and we find that the majority do go on to achieve a really strong, meaningful treatment response with the CBT that we deliver. We can also, related to that, remind them that most young people do improve. 80% of young people improve with CBT for OCD or BDD. And of course, us telling them that as either clinicians or you as parents or relatives is one thing, but I think it's an even more powerful message if it comes from somebody with lived experience. And so a really helpful tool can be to look for videos of hope. And I've given one example here, the OCD is Not Me video, which is freely available online. But there are many other podcasts and documentaries where people give an overview of their journey to recovery from OCD and BDD. And hearing these messages can be incredibly powerful, far more powerful, as I say, than anything that we as clinicians can be saying. So that can be a really useful way of sowing a seed of hope. I think it's also really important to manage expectations though. So whilst we want to be being very optimistic about recovery, we also want to be realistic about the time frame that might be required and the rate of progress. So we know that progress can be quite slow in the early stages of treatment, and that's because we have to spend time figuring out together how the problem works, what's keeping it going, and doing quite a bit of talking before we get on to sort of actively challenging OCD or BDD and actively using strategies to manage it. And when we do start using those strategies, we do it in a very graded way, as I've said. So we often start with the smaller, easier difficulties, and then move on to the sort of bigger challenges. So it's not unusual for young people to get halfway through treatment and feel that not much has changed in their day-to-day life. And we need to be saying that's normal, and it doesn't mean you're not doing a good job or treatment isn't working. What we do often see is that improvement really accelerates in the second half of treatment if the young person can stick with it. So another barrier is young people saying that they can't talk about their OCD. And again, this is quite common, and it's often rooted in either embarrassment or what we call thought action fusion. So I'll talk a little bit more about both of those. So embarrassment, OCD, most young people with OCD recognize that their worries and their behaviors are irrational and excessive. We call that insight, and it's a really positive thing. It makes us feel very optimistic about treatment. But the downside of it is that they often recognize that what they're doing or what they're worrying about, it can feel a bit silly and it can feel really embarrassing to talk about, and they worry that they're going to sound strange or weird. And in addition to that sort of general kind of concern, some versions of OCD involve very personal and private kind of content. So, for example, really unpleasant sexual thoughts, which can be incredibly difficult to talk about. So what we need to be doing here is really normalizing all of these experiences and saying, you know, there's nothing that the young person can say that would shock us or surprise us. These are very normal parts of OCD, and give them lots of examples of the different forms of OCD and BDD. And we hear lots about in the media, contamination fears or ordering and arranging, but OCD goes far beyond that. So the more examples we can give, the better. And I've mentioned thought action fusion. So this is the idea for some people with OCD, they worry that saying something out loud is either as bad as actually doing it, it's as morally bad as doing it, or they worry that if they say it out loud, it makes it more likely to come true. So it's sort of tempting fate. And so for these people, there's a real anxiety about verbalizing their thoughts. And I think if a young person is struggling to talk about their OCD, we should always be checking out with them. Is this one of the barriers? Do you worry that if you say it, something bad will happen? Do you worry if you say it, it'll make you a bad person? And if they can tell us that, then that's helpful in itself. We understand what the barrier is, and we can think flexibly about how they can communicate with us. Sometimes writing it down is easier. Sometimes if we give lots of examples, they feel able to nod their head or shake their head to give us some clues as to whether or not we're getting close. And we can work up to it gradually. Some young people tell us that they think OCD is just part of who they are. How can they ever change because it's part of their personality? In our treatment protocol, we spend time with everybody doing what we call externalizing OCD. So what this means is it's sort of actually having a conversation about how OCD is a separate problem. It's not part of who they are. It's a problem that's affecting them. And sometimes we do that in a very kind of concrete way. We might draw a picture of an OCD bully or an OCD monster and give it a name. And then from there on, we'll be talking about that sort of OCD bully or OCD monster in treatment. Sometimes we do it in more subtle ways. So it's the language that we use. We'll be saying things like, when OCD makes you check the door 10 times, rather than when you check the door 10 times. So that difference, when OCD makes you, is externalizing OCD. It's making it clear that there's a OCD bully that's giving you a hard time and trying to control you. It's not part of who you are. It's not your own choice. And I think separating OCD from one's own identity is really hard when you've had OCD for a very long time. And some young people, it does emerge really early in their childhood, and they genuinely find it really hard to remember life before OCD. But if there was a clear period of time in their life before OCD emerged, it's helpful to reflect on that. And that's something that you as parents and relatives can be thinking about and reminding them of times in their life where they were able to do certain activities without OCD getting in the way. And that just reinforces that message. It's not part of who you are. It hasn't always been like that. I would say that obviously that can be a sensitive topic, and for some people it'll be really upsetting because it brings home what they've lost and the impact that OCD is having now. So I think, it does have to be done carefully and thoughtfully, but if it's done in the right way, it can really remind the young person that this is not, OCD is not entwined with their own identity. And the other thing we can do is to reinforce other aspects of their identity. So for some people, OCD is pervasive and has infiltrated every domain of their life, unfortunately. But for other people, they've managed to keep many activities going. And the more we can sort of reinforce the things that they enjoy, the activities that make them who they are and that are separate to OCD, the better. And where there aren't actual activities, perhaps what we can do instead is focus on the aspects of their personality. So traits like kindness or compassion, and to be really sort of recognizing and spotting and reinforcing those traits in the individual when they're shown, just to kind of keep giving them the idea that OCD is not who they are in their entirety. Okay, so some young people with BDD tell us, well, in fact, many young people we meet with BDD tell us that they don't think they have BDD. They instead are convinced that they have a physical problem with their appearance. And slightly similarly, young people with OCD can say they think it's not a problem for them. They don't really understand why other people are concerned. OCD is not a problem for them. And I've put these together on the same slide because I think they're different kind of facets of the same problem. And the problem is lacking insight. So it's not recognizing the difficulty in the same way that we as clinicians and you as parents and family members are recognizing it. And I would say that the main thing here is to really try and avoid getting into a debate, because that will be futile. You may have had that experience before. For example, if you try to talk to a young person with BDD about whether or not other people see them in the same way, whether or not they really have a problem with their physical appearance, they're likely to get quite angry. They're likely to feel misunderstood. What they won't do is suddenly sort of change their perspective. Of course, it's not that simple. So getting into a debate is futile, and it's likely to just sort of end up polarizing you and lead to conflict. So instead, what you can do is to try and find some common ground. So your child or your relative might not be recognizing that they have BDD or OCD, but what they might recognize is that they're distressed. They're feeling sad, they're feeling anxious, and they might recognize the impact that it's having. They might say it's hard to get to school, it's hard to see their friends, it's hard to do the things they enjoy. And if you can find that common ground, the bit that you agree on, which is likely to be the distress and the impact, that's the sort of root in. And we can be saying, okay, well, maybe that's something we can work on. We can sort of work on building your confidence, managing your distress, getting you back to doing the things you want to do and improving your quality of life. So yeah, and I've also mentioned at the bottom there that sometimes it can feel like more of a problem for the family than the young person themselves. And that's often where the levels of accommodation are very high. So Blake Stobie spoke earlier about family accommodation. This is the idea that parents and family members often get very drawn into helping young people with their rituals and their routines, whether it's cleaning or avoiding situations. And they do that with good intention, because it helps the young person get through their day-to-day life. It might make the difference between them getting to school or not getting to school. But what that kind of means is that the burden of OCD is then falling on the parents or the family members, and the young person's left feeling, well, I am getting to school, I am kind of broadly doing the things I want to do. And the impact is much more one on the family. And I'm going to come back to talking about that in a bit. Okay, the last barrier that I mentioned was relevant specifically to people with BDD, that often we see young people who say they feel that cosmetic treatment, whether it's surgery or non-surgical procedures, is really the only answer for them. They can't see how psychological therapy would work, and they're really fixated on just getting the cosmetic treatment. I expect many of you are aware, but just to reiterate in case you're not, that cosmetic treatment is not recommended in individuals with BDD. What tends to happen is that there are high levels of dissatisfaction following these treatments, and that can lead to a real deterioration in mental state, actually, because people feel so disappointed. They pinned all their hopes on this treatment and it hasn't worked. So they can often end up feeling worse afterwards. So it's not a treatment we recommend, but this is going to be really hard for a person with BDD to hear. And what we don't want to do, again, is to sort of get into a debate about it and have lots of arguments about it. So I think it's important we communicate that message. We'd be concerned that the treatment isn't going to have the impact that they're hoping. But what we would ask them to do is to think about whether or not they'd be willing to give CBT a try and just put the cosmetic treatment plans on hold. So we say, you know, that cosmetic treatments aren't going anywhere. They'll still be there in the future. But what about just putting those plans on hold for a few months and giving CBT a go? What have you got to lose? So that would be our sort of way of framing it there.
Hey, Georgina, sorry for interrupting. I just want to say, I think we have about 10-15 minutes left, and that will take us on for a little 10-minute slot of question and answer.
Perfect, that's brilliant. Thank you. So what if you do all of this and your child still doesn't want or can't fully engage with treatment? Well, I'd say sort of generally it's better to wait and to not push treatment, because if we really force somebody to engage in treatment when they're not ready or they're not on board with it, it's very unlikely to work. And having a negative experience of treatment, an experience where it hasn't worked, is going to undermine their motivation to perhaps try it in the future. So it's much better to sort of accept that now might not be the right time, and that's okay. And as my colleagues talked about earlier, just because it's not the right time now doesn't mean it won't be in the future. And we see many young people who actually do come back in the future in a much stronger position and much better able to engage in therapy. So it's always worth sort of knowing when to call it and not trying to sort of just push through if really we know that it's not going to work. So, and I think the other thing to remember is that any conversations that you've had around identifying some of these barriers, you know, anxiety, hopelessness, all of these things, it's going to have been helpful, and it is part of their journey to recovery. And I find this, just having, here we go, my slides. I find this a really helpful model to think about this. So this is a stages of change model. If any of us are making changes in our behavior and in our day-to-day life, whether it's fighting OCD or BDD, or whether it's trying to live a more healthy lifestyle, we move from this sort of pre-contemplation phase, which is where we're not even thinking about it, to contemplation, where we start to kind of wonder about making changes, but we're probably quite ambivalent and uncertain, to preparation, which is where we start making some plans. an action where we start carrying out these plans and actually making changes in day-to-day life, through to maintenance, which is where we keep the changes up. And so maybe it's really unlikely that if somebody starts off at pre-contemplation, it's unlikely that we'll be able to get them all the way through to action and maintenance in a short period of time. But the kind of discussions we've been talking about are all contemplation. So it's all moving them forward in that recovery journey. And in the meantime, if a young person really isn't engaging in treatment, and this question did come up earlier, are there other things we can be doing? And the answer is yes. We can think about medication, a family of medications called SSRI medications, which we know are effective in the treatment of OCD and BDD. Having regular reviews provides an opportunity to not only keep the young person safe and make sure that there aren't any risks, but also keep up these conversations and this kind of contemplation, if you like, which might help move them forward in their journey to recovery. I won't talk about functional gains too much because Chloe covered this earlier, but just to say that sometimes where the impact of OCD or BDD is very severe, but the young person isn't ready for treatment, we are able to work with them to really just focus on functional gains. So it might be something like trying to get back to school. And we're not trying to target the core of their OCD or BDD. It's not treatment, but it's just about improving the quality of their life in the short term. And we just need to be explicit that if we're doing that, it's not treatment. We're not expecting them to get better from OCD or BDD, but it might help in day-to-day life. Reducing accommodation. So occasionally, if young people are unable to engage, we work only with family members, so just with parents. And there's a particular program that's been developed in the States called SPACE, which is supporting parents for anxious childhood emotions. And that's all about working just with parents to, the aim is to reduce their involvement in the OCD or BDD so that there's less of a kind of burden on them. And sometimes a side effect of that is that it improves the young person's insight. They start to recognize more the extent of the problem and become more willing to work on it. And then, of course, support groups are really important, both for the young person themselves and for you. And I would definitely recommend BDD Foundation and OCD Action as sources of information for those. So just in the last few minutes, and I can whiz through this quickly because it's much more about practical tips. I mean, obviously, we've all been working remotely as a lot more than we had over the past 15 months because of the pandemic. And we know that CBT is as effective as face-to-face treatment when it's delivered remotely. And we ourselves have done research study to show that. So it really can work in this remote format. Of course, it's not for everyone, and the therapist would need to be thinking very carefully about issues like whether or not exposure can be done safely in a remote setting, whether or not certain comorbidities like autism spectrum disorder or ADHD are present. But we know that people feel quite hesitant sometimes about remotely delivered CBT. And these are some of the common concerns that we hear. I'm no good with technology. Remote therapy isn't real therapy. There's no quiet place in my house. My child won't form a relationship with a therapist. We won't be able to do exposure with response prevention. Things are better at the moment. Why would we rock the boat? So in the last few minutes before we have our question and answer session, I'm just going to mention really some quite practical tips, which are based on our experience and our reflections from the last 15 months. So I think one thing that we found really helpful is arranging a sort of test run ahead of time to check that the technology is working. So I think us presenters today have been very much aware of a few technical glitches, and we know that these glitches can be quite stressful and they can also take up quite a lot of time to resolve. So you don't want to be starting your CBT session like that. So having a test run with a therapist or somebody within the clinic, or if not, a family or friend, to check that it's all working ahead of time can be really useful. Also, practical tips like using an Ethernet cable so that the Wi-Fi doesn't cut out, trying to reduce the burden on Wi-Fi by not having other people accessing it within the house at the same time, quitting other applications on your computer or your device so that Teams or Zoom runs more smoothly. And just to highlight as well that, of course, there are positives. So the fact that people can join from different locations, a parent who might be at work can still join the call, and that can be a real asset. I think if there's no quiet place at home, which is often the case, there are other people in the house, it's hard to find a quiet space. Of course, using headphones, as many of us are doing today, is really helpful. Just thinking with being open with your therapist and saying, look, at 4 o'clock, that's when all the kids come home from school, the house is chaos, that's not a good time, and trying to think about the best time. And also just being practical and thinking about whether or not others could go somewhere else to create that space within the house. And even when noise and distraction in the house isn't an issue, just thinking about the surroundings. So, making sure that there aren't too many sort of nice distracting things for the young person to be grabbing or paying attention to during their CBT session, trying to have it as quite a kind of clear and calm environment. This is something that we touched on earlier as well. So my child won't form a relationship with a therapist in a remote format. Well, we know that that absolutely isn't always the case, and it actually is surprisingly easy to establish a genuine connection working remotely. We know that for some young people, it might be harder. And so perhaps having a little bit of a chance to get to know their therapist before jumping in with the content of CBT can be helpful. Perhaps the therapist can share a profile, a bit of a letter, or sort of summary of information about them and who they are to help the young person feel connected. We won't be able to do exposure with response prevention in remote therapy. Well, that absolutely doesn't have to be true. You don't have to be together in the same room to be doing ERP. I think therapist-assisted ERP is really important. So it's important that it's included in the sessions, but that doesn't mean that the therapist has to be physically in the same room. And in fact, on the contrary, that the most effective exposure tasks are ones that kind of take place in the young person's natural environment. And a home, it's obviously one of their main environments that they're in. So often rituals and routines are linked to home. They might be linked to the bathroom, for example. So actually being able to have a session where the young person is at home provides a real opportunity to practice resisting and challenging rituals and compulsions in their sort of real life setting, if you like. So just some other practical considerations that you might ask your therapist to share materials ahead of time so that you've got something physical to look at other than just them on the screen. If there are worksheets for that they're expecting the young person to complete, make sure that you have those printed out ahead of time. And thinking about how you can manage distress. So if they do get anxious doing exposure tasks, for example, talking through with the therapist how you as a parent can support your child in those situations. And I've just mentioned the video camera as well, because this is obviously a really big one in BDD. Most young people with BDD that we see find it really hard having the video camera on at the start of treatment, and that's fine. But I think it is really worth having that as a goal in treatment, to be able to sort of say, okay, let's not worry about it for the time being. But once we get going in treatment, we'll talk about that some more. And we maybe will start to think about ways of gradually making that possible. So just keeping it on the radar and the agenda. And I'm going to finish now with just a quote from a parent. So this is a parent whose child did have CBT remotely. And they said, at first I was a bit skeptical about video therapy. I thought it wasn't going to work. After a few sessions, though, I realized that it was actually even better. Being at home, tasks were more relevant, meaningful, and tailored to my son's need. At the clinic, we would have had to simulate the tasks in an unfamiliar environment, come back home and find our own ways. Having the therapist at home with us made things much easier, as she could guide us step by step, making sure we did it in the right way. So I'm going to finish there. Thank you so much.